Hello and welcome to this session. This is on using behaviour change science to help people with Parkinson's disease be more active. We're looking at translating the evidence into practice here. My name's Dr. Jennifer Cartwright and I'm joined by my colleagues Professor Leanne Hassett and Miss Jo Dawson. And we're together with the Institute for Musculoskeletal Health through the University of Sydney. The three of us are involved in behaviour change trials around helping people with chronic conditions and disability be more active. We're also involved in coaching and motivational interviewing ourselves. And we're also doing some work around looking at interventions to support health professionals to help their patients be more active by implementing some behaviour change techniques. And we'll share some of the research that we're doing throughout today. So this session is divided into 3 sections. Section 1 is on why physical activity for Parkinson's, why is it important, and also why is it hard. We'll look at the evidence, the barriers, and the clinician's role. Section 2 is on understanding motivation and behaviour change. So we'll look at the science behind the strategies for how you can help your patients be more active. And then section 3 will be on practical tools for the clinic. So we'll share with you the 5A's framework for physical activity promotion and share with you some resources that you can use in your clinic to start helping your patients be more active. But for now, I'm going to hand over to my colleague Leanne, who's going to take the first session on why physical activity for people with Parkinson's and why it's hard. Thanks, Leanne.
Thanks, Jen, and hi, everyone. So I thought it was important to just start broadly with, what do we mean when we talk about physical activity? Well, physical activity is a broad term, and it's really about any type of movement, any type of activity that we do. And it can be talked about in different domains. So we can think about that we can be active in our transport, like walking to the library, for example, or to the shops. We can think about being physically active in work that we do. So if you're working, for example, in a construction job, you would be very active, as opposed to if you had an office type job where there's not much physical activity that happens if you're just sitting at a desk. You can be active in household activities, and gardening is a really good example of a great physical activity that people can do. And you can be active in lots of different leisure activities. So we can think about participation in sport, think about participation in recreation activities such as dancing, and then just the typical exercise. And we can think about the type of exercise that physiotherapists and exercise physiologists prescribe as well. And so also when we think about physical activity, we can think about different intensities of activity. So we can have light type of activity where you really don't get much raise in your heart rate or really huff or puff at all. Like if you were just going for a really gentle walk, perhaps with a neighbour and having a chat while you're doing that, that might be considered just light activity. You can have moderate physical activity, and that's where your heart rate does start to raise more and you do huff and puff a little bit. So you could still carry on a conversation, but you'd be a little bit breathless while you were talking. And then we have vigorous physical activity where there's lots of huffing and puffing, your heart rate can get quite high, and you might be able to talk, but it's really, quite difficult to talk because you're working at such a high intensity. Okay, so that's sort of a broad overview of what physical activity is and how we think about it. So why is physical activity important for people with Parkinson's disease? Or, what could be some of the benefits to encouraging your clients with Parkinson's disease to be more active? Well, there is some good evidence to show that there are a number of benefits in Parkinson's disease. So it has, depending on the type of activity you do, it can improve a number of motor skills. So it can improve your ability to walk, to balance. It can reduce some of your Parkinson's disease symptoms and also can reduce the risk of falls. Physical activity also has potential to improve cognitive function. Can help to improve people's mood, and also quality of life. And particularly, I think that comes out when you think about the social connection that can happen with being physically active. And there's also some evidence that it can have a neuroprotective effect as well. So it may help to slow that disease progression in Parkinson's disease. So we've done a bit of research in our group, just trying to understand around, what is some of the evidence around different types of physical activity that people with Parkinson's disease could participate in. And so this was a large systematic review that we did. And this one was focused particularly on physical recreation. And so activities like dancing, Tai Chi, yoga, water, exercise, going to a local gym, all of those types of recreation activities were included in this review, and we only included high quality randomized controlled trials. And so we were interested in what were the benefits. And this was looking at a broad population of people with physical or intellectual disability, but the majority, I think, of the studies included people with Parkinson's disease. And so what this table shows is just where we found evidence of the benefits of these types of activities on different outcomes. And so the bright green shows that there is clear evidence of effectiveness, and the light green shows that it's looking promising. So it does look like it benefits participating in that type of activity compared to not participating in any activity, but it's just a little bit less certain. And the white bits is just where we're not able to show an effect at all. And so what you can see is that there's lots of bright green. First up, if we just look at all the studies included together, so regardless of what type of health condition the person has, you can see that there's lots of clear evidence for improvements in people's mobility, their walking, endurance, their balance. There's also some evidence of improvements in quality of life, reducing people's fatigue, and also depression and anxiety. And if we look specifically in Parkinson's disease, we can see that the strongest evidence is in those mobility type of activities. So there's definitely clear evidence that these types of physical activities, so that dance, yoga, Tai Chi type of activity, can improve mobility, walking endurance and balance, and with some evidence there around reducing fatigue and improving people's levels of depression. So that's sort of showing about what are some of the benefits and what is some of the evidence behind that. So now let's have a bit of a think about how much physical activity is recommended that people participate in. And many of you may be familiar with the World Health Organization's physical activity guidelines, so the international guidelines. They were last updated in 2020, and these were one of the first guidelines that included recommendations for adults and children living with disability or chronic conditions. Now, the Australian physical activity guidelines have actually just been updated as well and only just released last week, although an official launch will happen later this year. But these Australian guidelines now also include recommendations for people with disability or chronic conditions and have quite similar recommendations to what WHO have. And so what is recommended is that people should try and do at least 150 minutes or more a week of moderate intensity aerobic exercise. So as I said, that gets you huffing and puffing a bit. Trying to do that, at least 150 minutes or more a week, at least 2 days a week doing strengthening types of activities, and 3 days a week also doing functional activities that target mobility, balance, and coordination. Now, it's important to remember that some of these different categories can be combined. So It's not that you have to do that 150 minutes, then definitely then 2 separate days of strength and then 3 separate sessions of functional activities. That a number of, for example, strengthening exercises can be done in a way that will also have those functional type of activities that challenge people's balance and mobility as well. So a great example is sit to stand activities. So that can be a way to get your muscle strengthening, but also to get that functional activity happening. Now, I know for some people that these levels of activity is a long way off where they currently are, and so can feel not possible. And I'm sure that many of you can think of clients that you're working with that these don't seem possible. So it's also very important to remember that no amount is too small, that even just starting to be a little bit more active than what someone currently is likely to have a number of benefits. And if someone isn't doing much and starts to be active, it's important that they do start small and that there's that gradual progression as people try to build up as much as they can towards this recommended guideline level. And it is important for people who do have health conditions such as Parkinson's disease that they may need the support of a health professional such as a physio or an EP to support them to be able to safely increase and choose the type of activities that they're going to get the most benefit from and that they're going to enjoy as well. That's what people are meant to do. So do we think people currently meet physical activity guidelines? Well, I think none of you will be surprised to know that many people do not meet physical activity guidelines, even if we're thinking about the general population. But in particular, if we think about people who have health conditions such as Parkinson's disease, then they're even more likely not to meet these physical activity guidelines. And there's a number of reasons why it's difficult to meet these guidelines. Some of the patient barriers that are talked about is fatigue gets in the way. And so that challenge of feeling tired and think that if they're physically active, it's going to just make them more fatigued. And also in Parkinson's disease, their fluctuations in their motor ability might be another challenge. They may have a fear of falling and causing injury to themselves. And confidence might be a problem as well, that they don't see themselves as an active person, particularly if people talk just about exercise as opposed to that broader physical activity. One thing we have seen, there's been some nice studies that have shown that when a clinician talks about physical activity with their patients, that does make them more likely to be active from that discussion, and often multiple discussions, which you'll hear more about later on. But this again is then challenging for clinicians to be able to do. And some of the barriers that clinicians talk about is that they're limited in how much time they get to speak with their patients. Sometimes they can be uncertain about the safety of exercises to actually recommend people to do, particularly out in the community. And they just may not have the skills of how to have those conversations and help them to support that behaviour change. So these are some common barriers specifically in Parkinson's disease. So some of them already covered before. So from the patient perspective, that fatigue and the off periods of their medications during the day, the fear of falling, low confidence, limited accessible exercise options can be a challenge as well. And their symptoms fluctuating, which particularly if they get into a nice routine of being active, then that can be a challenge to keep that routine going. And from the clinician perspective, as we've talked about, that difficulty fitting everything into the appointment time, uncertainty about what to prescribe, that lacking that framework for the behaviour change conversations, and that difficulty being able to follow up on how the patients are going with their goals in physical activity and thinking about how to set those goals on physical activity. So this is some other work that we did in our team. This is using data from AusPlay, which is the Australian survey on physical activity that's conducted. And so we were able to do an analysis of survey data over a couple of years we're able to compare adults who reported having a disability, so having some type of limitation in their activity, and we were able to compare that to adults who reported not having any disability. And so in the red is the percentage of adults with disability who were meeting that at least 150 minutes a week of that moderate physical activity through leisure time physical activity, such as that sport, recreation, and exercise. And the blue are the adults with disability, adults without disability. And so what you can see is that as soon as we sort of hit the 20 years old right across the lifespan, we can see that adults without disability, there's a larger percentage who meet at least that 150 minutes a week. So that guideline recommended level of physical activity. So we can see right across the lifespan that people with disability are always less active. And within that work as well, we explored about some motivators and some barriers for people who currently weren't being active enough. What would motivate them to be more active? And again, same colouring for our adults with disability in red. So what we can see is that there's actually quite similar motivators for people with and without disability. So improving someone's physical health and fitness is kind of the number one motivator for why people want to become more active as well. But we can see that fun and enjoyment is a key motivator as well for both groups. That's a really important one to remember. But when we look at barriers, so what stops them, we can see that actually it's quite different between adults with and without disability. So we can see for our adults with disability that poor health or injury is the main barrier that's stopping them, where for adults without disability, it's time that they report. And so if we think of that barrier is that poor health or injury, that again shows that really key role for a health professional to be able to support someone to be active, to really be able to work with them to select the type of physical activity and to help them to set that dose and progression to make sure that it is safe and it doesn't cause injury for them. So this is a good time to pause this recording, and we just thought it was worthwhile you just taking about 30 seconds to think about maybe one or two patients that you're currently supporting and think about, what type of barriers actually, stop them being physically active. What comes up most common? Have you tried anything to help them get over those barriers and become more physically active? Or do you feel that it just, is there something that just doesn't quite ever shift, some barrier you can't really overcome? And do you think there might be a different way that you could approach your conversation that might help them to overcome some of those barriers? So just pause and have a think about that. So just in finishing off this section, I think it's really important to talk about that we really think there's a key role for clinicians to help patients, particularly people with Parkinson's disease, to become more physically active. So as health professionals working with people with Parkinson's disease, we can think about how we can promote physical activity each time we see our patients. So that raising the topic of physical activity in each of our interactions, it's a great opportunity to be able to do that. We can develop skills in health coaching and motivational interviewing that make our ability to be able to raise that topic of physical activity easier to do and easier to fit into your consultation. We can provide that structured exercise, and I think physios and EPs already do this and are very good at doing this part of the physical activity. But we also can then think about people may not want to do structured exercise for the rest of their life. They may want to look at other types of physical activities that might be more enjoyable and sustainable. So how can we think about referring our patients onto community types of activities as well? Also thinking about ourselves, we can practice what we preach, so be physically active ourselves. We can be promoting physical activity within our workplace so that it becomes a social norm, that physical activity is talked about with our patients. And we may also want to be involved in broader conversations and advocacy around changes that physical activity can be better supported for people. As clinicians, there's lots of different ways that we can bring physical activity conversations into our interactions with our patients. If we have a very short period of time, we can still provide very brief interventions, where, as I said, we're really just raising that topic of physical activity each time, providing that encouragement to them about it, and potentially setting a goal around physical activity. If we have a bit more time, then we've got a bit more time to have discussions, provide a bit more advice and think about that referral as well. And if we are seeing patients for a longer period of time, which is often quite common for working with people with Parkinson's disease, then we can have this extended brief intervention where it can happen over multiple visits, where you can really be addressing people's barriers and using some really key behaviour change techniques like the goal setting and self-monitoring to be able to support people to change their behaviour and become more physically active. And we've done that in large trials. So this is the comeback trial, and the results of this study are going to be published very soon, I hope. And this was a health coaching intervention that was delivered by physiotherapists who had a lot of experience working with people with a range of different health conditions and had difficulty with their walking. And we were able to show that this telephone-based health coaching was able to improve people's physical activity levels compared to people who didn't receive this physical activity coaching. And so I think that's all I wanted to share with you today. I'm going to hand over to Jen, who's now going to take over and talk about the next components. Thanks, Jen.
Thanks so much, Leanne. That's such a great overview and introduction to, really establishing why physical activity is so important for people with Parkinson's. But yeah, as you outlined, and I'm sure many of you listening in today will really see that there are so many barriers and challenges, despite the best intentions of patients. And so this next section will look at understanding motivation and behaviour change and how you can start using the science to embed some of these strategies into your practice and the strategies for your patients as well to help them be more active. So my name's Dr. Jennifer Cartwright, and let's get into this section. So I'm sure you're all familiar with this motivation continuum, which really outlines, there's a spectrum for motivation. It's not black and white. Down at one end, we have amotivation, which is where someone is really not motivated. They're really not ready for change. They don't see the importance. It's not relevant and it's not part of their lives. In the middle is extrinsic motivation. So this is where people are motivated by external things. So it might be, my doctor told me to, or my husband's nagging me, or my wife's nagging me to be active, or, I want to do it for my kids. And this is a slightly stronger form of motivation. And we can certainly use this in our practice. So in your practice to have external motivators. So things like rewards, external encouragement can be really valuable. But ultimately, where we want people to sit is intrinsic motivation. And this is because when you're intrinsically motivated, you're so much more likely to initiate and maintain that behavior long term. And you'll hear patients say things like, I feel so much better when I move, or I enjoy it, I look forward to it. And perhaps you can relate to that on a personal level as well, practicing what you preach, seeing the value of physical activity. And The intrinsic motivation is really when people intrinsically value it. It's part of their value system that I enjoy being active. I see the benefits. I love, being outdoors or socializing, whatever parts of things that they value about physical activity. The more we can shift people to being intrinsically motivated, the more likely they are to stay active long term. And this is where you come in with your skills and your questions and in your consultations, that you can actually support your patients to make that shift to be intrinsically motivated. So you're probably familiar with self-determination theory, and this really outlines that there are 3 building blocks to have someone support them to become intrinsically motivated. And very conveniently, they all start with C. So the first is connectedness. So this is where having social links, being part of group exercise or group activity, not everything has to be formal exercise. Having a shared experience, being related to, so important for intrinsic motivation, having it being valuable. And this is really where your role comes in as the therapist, is that idea of therapeutic alliance. The power of one clinician, believing in your client that they can change, that they can do this, really can't be understated. The second building block is competence. So this is when, to be able to do something and keep going, you need to feel like you can do it. So feeling competent in the behavior. And this is when building confidence and building a patient's own sense of competence through small achievable goals. So Leanne presented the physical activity guidelines before. For a lot of clients, maybe with Parkinson's as well, these are just simply unachievable from where they're at the moment. So this is when building small achievable goals to start building that confidence, building their sense of competence, can get them on the way to intrinsic motivation. The third building block is control. And this is when offering choices, supporting your patients to become independent and really respecting their own autonomy, asking them, what would you like to do to be more active? What's important to you? And really reinforcing, it's really up to you whether you'd like to make these changes, which for people that have been on a health journey, they've probably had a lot of feeling out of control, and that feeling of dependence on the health system, being told, diagnosed, and here's the treatment regime. Physical activity is one thing where you can really put the control and the power back into the client's own hands, which really can go a long way to have them becoming intrinsically motivated. So if you think about motivation as a driving force, so ideally someone that is highly motivated, they'll feel confident, they'll feel competent as well, they'll have that sense of control, and they can see the point. They have that positive attitude to physical activity. This then makes them more likely to increase their physical activity, which, as we know, as Leanne laid out before, all the positive benefits. They're going to feel good. They're going to see their fitness and mobility improving, more energy. They'll feel that social engagement, and it'll be fun as well. So that obviously then increases their motivation, which creates this lovely positive spiral. Obviously, on the flip side, that negative spiral can happen as well. And this is really where starting with motivation can start getting your patients to being that little bit more active. Colin Greaves, so if this was from the comeback study that Leanne talked about earlier, and this is a roadmap for change for your clients. So again, really starting with motivation. So providing information, but providing it in a way that we'll explore a bit later that isn't, dumping on patients, but it's a real collaborative way of your patients discovering, what are their reasons, what's important to them about being active. Exploring ways to enhance their motivation, really engaging that social support as well, and then feeding into that blue phase, so of action. And that really starts with making an action plan, planning, when are they going to be active, where and how, and then a coping plan as well. What's going to get in the way and how will you cope, how will you plan around that? And then trying it out. The idea of a mini experiment is really powerful in behavior change. You're not locked into this plan. Just give it a go. See how you go. Try it for a week. Monitoring progress as well, which we'll talk more about, self-monitoring. And then shifting into that purple phase, which is maintenance, reviewing your progress, reviewing motivation and social support, and keeping this going, ideally as a lifelong habit. And part of that is obviously dealing with setbacks. Things will pop up, health things, external things that will feed back into, okay, a reset and refocus, make a new action plan. The COM-B model is really valuable, and this outlines that there are 3 things that determine and drive your behaviour. So if you think about in blue, that example of someone's going to do a home-based exercise program 3 times a week. I know we've said physical activity is broader than that. Let's think about this for this example. So the 3 things driving that are capability, opportunity, and motivation, so COM. And the capability is both the psychological capability, so do they know how to do the exercises, and the physical capability, so do they have the strength or perhaps, the coordination, the balance to do what they want to do. In the middle is the motivation. So there's 2 types of motivation. So reflective motivation is, you have that belief in the importance of the exercises themselves and how they will benefit you. Then the automatic motivation, which is how the exercise will make your client feel. Then there's the opportunity. So there's both the physical opportunity. So do they have the space in their house? Do they have the equipment? Can they get to the gym to do it? And then the social opportunity as well. Do they live alone? Do they have a spouse? Have they got someone supporting them, perhaps a friend or perhaps another health professional as well? So thinking about all these things that feed into whether they're going to be able to get started and keep it going. But you'll notice as well, those arrows go both ways. So once they start doing the thing, that will then have them feel more capable. That will help them feel more motivated, and it'll open up new opportunities as well. What's really valuable about the COM-B model is that it's a clinical diagnostic tool as well. So when you have a client in front of you who perhaps wants to be more active, or you're trying to support them to be more active, before you choose a strategy, diagnose the barrier and ask what's stopping them. Is it a capability thing? Do they have perhaps a fear of falling or uncertainty? Do they have low confidence, or perhaps some of their physical symptoms are getting in the way? Do they have the opportunity? Do they have access to a program? Do they have any support? Or are there cost or transport barriers? And is there a motivation barrier? And I'm sure we've all got a client or 2 in mind where motivation is, the glaring thing in lights. That's the thing stopping them. And this is when patients will say things like, I'm not an exercise person. I don't see the point. They might have low self-efficacy, and they might be at that amotivation end of the spectrum. So really thinking about which one of these 3, and it might be more than one, is stopping that person, because then that guides your strategies and how you're going to support them. This is a really quick introduction into the idea of health coaching, which you might be familiar with. But health coaching is really a conversation that elicits behaviour change by supporting people to make sustainable changes. Health coaching is patient-centered, so this is really key, and again builds that sense of autonomy and competence. So when you're setting goals, have the goals be determined by the patient, and perhaps you can collaborate together to have them be realistic and safe, but really important that they're not imposed. There's a process of active learning with coaching, so we'll talk about this a bit more with motivational interviewing, but really encouraging, it's a process of self-discovery. You've all got a wealth of experience, a wealth of clients that you've helped. For this client that's in front of you, this is their own journey that they're starting. So really walking alongside them rather than kind of that top-down approach of, I have the answers and here they are. What are your patients' own answers, and can they discover them for themselves? Self-monitoring is a key part of health coaching because this builds accountability and insight, and we'll talk about some ways to support patients to self-monitor in a moment. But then intrinsic motivation as well, because this develops the patient's own reasons for change. And the why, why does your patient want to be more active? This is really the foundation. This is the starting point for all of the coaching that we do in our clinical trials. Really starting with why is so important. So we'll move on to a little bit about behavior change techniques. And these are defined as observable, replicable strategies that change behavior. These are really, the active ingredients of effective physical activity promotion. So there's been work done by Susan Michi and an international group of behavior change scientists that have identified 92 different behavior change techniques, but some of these are in the external range, things like rewards or punishments and things. This group here have worked out that there are a few key behavior change techniques that are the most effective for physical activity in people with disability. So these are the most relevant to your clients. And these are things like goal setting, starting with a goal, agreeing on a specific achievable goal. And it's really important that it's a behavioral goal. So thinking about the two types of goals. So you've got an outcome goal. Your client might have a goal of, I want to be able to walk 500 meters to the local shops. That's an outcome, but what's the behavior that's going to get them there? So, you might start with, and where is your patient at the moment? What's realistic for them? It might be, I will be doing 5 minutes of walking 3 days a week. That might be their starting point as a behavioral goal to help them get to that outcome that, the outcome is what's important to them, and helping them link that behavior to the outcome. Self-monitoring is really important as well. So this is when you support patients to track their own activity to build awareness and accountability. Monitoring is really useful as an objective assessment tool for you as clinicians, but it's so powerful for a patient to see their own progress, to see what they're doing, and then as they see themselves get better over time. It's so powerful to build that awareness and accountability. And there's a bunch of different ways. We've all got, most of us have smartphones these days that are tracking our steps, whether we like it or not. And sometimes for clients, it's as simple as helping them, open the app on their phone and look at where the steps are, if they carry their phone when they're out walking. There's plenty of other ways as well, like smartwatches or pedometers, or even an old school, pen and paper, like an activity diary to track, have I done my walk this week, and being able to tick it off, seeing that reward of, yeah, I've achieved that this week, builds that, gives them a dopamine hit in their brain that builds that intrinsic motivation to make them more likely to carry on the behavior. Action planning is a really great behavior change technique. So starting off with, when, where, and how will they do it? And I think this is something as clinicians, if we have a couple of minutes, really exploring. So once you've set a goal, so your patient wants to walk 5 minutes 3 times a week. Okay, when are they going to do it? Will they do it in the morning? Will they time it around their medication, or when, their carer or support person's there? Where are they going to walk, and how will they do it? What can they put in practice that's going to make them likely to do it? Will they put up a reminder for themselves? So really drilling into these details and having your patients say it as well. Having your patients identify when, where, and how is really powerful for change. And then looking at social support too. So there's some different types of social support. So there's the information, which is often where you come in as clinicians. There's emotional support, obviously where you come in as well, providing that encouragement, and also looking at, have your patients got anyone, any significant others or friends that can offer that emotional support. There's strategic support as well. Have they got someone to walk with that's useful for that accountability, but also perhaps a little bit of competition as well. And practical support too. Maybe they need a lift to the gym or wherever they're to their group class. Thinking about the different types of social support, and again asking patients, who have you got in mind that could help you achieve this goal of walking 5 minutes 3 times a week. We'll start on motivational interviewing now. And this is work done by Bill Miller and Stephen Rolnick, have really pioneered this area over the last few decades. And they talk about motivational interviewing as being a particular way of talking with people about change and growth to strengthen their own motivation and commitment. And they talk about the spirit and skills of motivational interviewing. So the spirit is really being empathic, expressing that empathy, understanding their world without judgment. I know as clinicians, we often do have our own judgments around, particularly we know the benefits of exercise, we know the guidelines, we know how good it would be for patients, but sometimes just understanding their world, look, it can be really hard to make a change. It can be hard with all these barriers. And having, as a client, feeling heard and feeling understood really can't be understated for helping someone change and grow. Supporting self-efficacy. So we've really covered this a lot, but, really believing in their ability to change. They might not believe in themselves. They might have really low confidence. But if you can believe in your patients and let them know that, that really goes a long way to help them develop their own self-belief. Rolling with resistance is a key thing. I feel like as clinicians, we often, and we're trained, we have the answers, we know the guidelines, we know how to put it in practice. But if we feel like we're in a consultation and feeling like there's some resistance, there's maybe arguing or confronting, is really to pause and think about walking alongside your patient. So Miller and Rolnick talk about motivational interviewing being a dance rather than a wrestle. And if you feel like you're wrestling with patients, there's always something that, we can shift. And it's often just to pause, sit back and just walk alongside. And again, coming back to that empathy, it sounds like there's a lot of things and change can be hard. Really just emphasizing making a change is hard because we're creatures of habit. Developing a discrepancy as well. So exploring that gap between what they're currently doing and what they'd like to be doing. And this is where thinking about, what would they like to be doing in the future and how do they think their future would look like if they continue to, be the way they are, if they continue to not do much exercise or activity. How do you think they're going to be in a few years' time? And inviting them to have that self-reflection. There's 4 skills in motivational interviewing. They love their acronyms. This is the OARS acronym. So open-ended questions. So rather than a yes/no question, thinking about, what and why and how questions. What would you like to do to be more active? And how do you think you could do it? And why would that be important to you? Affirmations are great. So when your clients express some kind of, desire for change, or they talk about perhaps they've made some small changes, really picking up on those and affirming them back, because that helps your patient, develop the belief in themselves. And, being encouraging really goes a long way. Reflections are really valuable. So simply reflecting back what the patient's just said. So, you might ask them, what are your best reasons for being more active? And they might say, oh, look, I want to have better mobility. I want to stay independent in my home. I want to play with my grandkids. Reflecting that back. And so saying, it sounds like you'd like to be more active so you can move around more, stay in your home and be with your family more. Hearing your own words reflected back at you is really, really powerful. So a reflection is a really powerful thing to use in your practice. And then summaries are important. So this is when a client might talk a lot about, perhaps what they'd like to do, but also perhaps what's stopping them. And there might be a few kind of themes arising. If you can summarize that and then present it back to the patient, so on the one hand, it sounds like there's a lot of challenges, perhaps around your mobility, you might be afraid of falling. But on the other hand, it sounds like being active is really important to you. And so presenting that back to the patient again can just prompt that, self-reflection and insight. So that's the spirit and the skills of motivational interviewing. One of the key approaches is the elicit, provide, elicit approach. So I think we've all had that experience of clinicians of, I've got this wealth of information and I just don't think I'm getting through to my patients. Try this approach instead. And this is when you elicit first. So you ask permission, can we spend a few minutes talking about physical activity and explore what they already know? What do you already know about how activity or exercise might help with Parkinson's? And then once they give you that answer, offer some brief tailored information. Would it be okay if I shared, what the research shows, because it might be relevant to you? And then eliciting again. So inviting their response and check their understanding. So what do you make of that? What feels most relevant for you? So that's the elicit, provide, elicit approach. If you feel like all of your reasons and information's falling on deaf ears, then try this approach instead, as a way of getting your patients, on board and thinking about what they would like to do and why. So just another opportunity to pause and reflect and think about how you currently talk about physical activity or, exercise, home exercise with your patients. How much of the conversations you have is advice giving versus drawing out their own motivation? When a patient resists or maybe disengages, what's your usual response? Do you push back? Do you go to try and emphasize the reasons more? How do you normally approach that? And what's your experience of that with your clients? And then thinking about, what would a conversation look like if you started with their why before the what? Before you start with that structured exercise program, or even before, exploring broader physical activity, what's their why? What are their reasons for change? What's important to them? What's important to them in life generally? And can you link that to why being active is important? So, key takeaways in terms of behavior change science: find the why first. This is so key. We start with this in our coaching. And if you can introduce, one small change into your practice, it could be this, thinking about what are their reasons for change, because intrinsic motivation is way more powerful and durable than extrinsic. Diagnose with that combi, what's stopping them? Is it capability, opportunity, or motivation? And then what strategies do you need to use to address that barrier? Think about applying those BCTs, the behavior change techniques. So those 4 key ones of goal setting, self-monitoring, action planning, and social support. They're the most effective for people with disability, people with Parkinson's. And then using those, the 2 acronyms. So using those open-ended affirmations, reflections, and summaries, and then that elicit, provide, elicit technique, because they're the skills for having a productive conversation in limited time. And, these approaches really work. There's some pretty powerful evidence showing that even just a couple of minutes, a couple of really carefully crafted questions to have your patients starting to talk about and think about change can really start getting patients moving. In the next section, we'll put these into a practical framework that you can use. But just to finish, I just want to touch on ambivalence, because this is a really normal part of change. And ambivalence is when you're feeling pulled in 2 directions. So your clients might want to be more active. They can see the benefits and see the evidence, but there are reasons in the way. There's things stopping them. That might be their own disease, their own symptoms. There might be external barriers. It might be a motivation thing, and it's not resistance, and it's a really normal and expected stage in behavior change. So here's what not to do. Truly try to avoid lecturing or arguing, because this triggers that resistance. And this is the righting reflex. We have that contrarian part of our brains where if we're told something, perhaps our partner or a friend or a health professional will suggest something to us, part of our brain will immediately come up with a reason against that, an argument against that. So really trying to avoid that. Try to avoid pushing for commitment before they're ready as well. Really, that starting with their whys is so important. And try to avoid dismissing or minimizing their concerns, because for a client, feeling heard and seen and validated really goes a long way. So, it sounds like this is really hard, and really emphasizing that change is hard as well. What to do instead? So exploring both sides with empathy. So, okay, so what's good about staying the same? What's good about, perhaps not being active or keeping things going as they are? And what concerns you about that? So thinking about what might your life look like in a few years' time if you carry on, the way things are at the moment. Steer it towards positive framing if you can. So what would being more active make possible? What would that open up for them? Imagine you can do that 500-meter walk to the shops. What do you think you would notice? What might change? And inviting that from your patients can really get them thinking about, that future self of, oh, I can walk to the shops, I'll see my friends, I'll feel more connected, and all those kinds of things. and working with their readiness stage as well. So still thinking, as Leanne said before, no amount is really too small. There's really strong evidence that even just a few hundred steps a day can confer some health benefits. A little bit about our Promote PA study. So for the past few years, we've been supporting teams of health professionals to embed physical activity promotion into their practice using things like motivational interviewing and behaviour change techniques. So it's a big randomised controlled trial. We've had 32 teams from across Sydney and beyond Sydney as well. And what we've found as well, so offering support, offering training and in-services as well as resources for their patients. These frameworks, which Jo will talk about in the next section, really supported the clinicians that we've worked with in having these conversations about activity. That education and upskilling really supported some practice changes for clinicians. And the resources that we've provided, which we had a searchable physical activity directory, and that helped clinicians support their patients as well. Just a little bit on some early feedback. So we've had clinicians say, look, I've started using the step count with my patients. I wasn't doing that before. And it's a really nice way of helping people monitor their own activity. So that idea of self-monitoring. Looking at the importance and confidence scale. So when you're asking patients, what's important to them about being active, can they put it on a scale of 0 to 10? And introducing those scales for this clinician was a good way to have that conversation in a positive way. We also said, some clinicians say, look, it is really hard to apply. And again, behaviour change for patients is hard. This is behaviour change for you as clinicians, and it can be hard to make a practice change. And this clinician identified, look, what my patients need is to be able to see it visually, like this is possible, perhaps through peer support, perhaps through role models as well. So that comes to the end of my section. Thanks so much for listening, and I will pass over to my colleague Jo, and she's going to give you some practical tools for the clinic. And I'll hand over to Jo. Thanks, Jo.
Hi, I'm Jo. So thank you, Leanne and Jen, for going through both, our expectation in terms of, physical activity with Parkinson's, but also going a bit into depth in terms of motivational interviewing and health coaching. And then this next section is really focused on trying to apply a lot of those, that theory behind motivational interviewing and health coaching in more of that practical sense. So what we're looking at is the 5A's model, which is a flexible clinical framework. So it's a framework that's been developed for things like smoking cessation and alcohol abuse. But what we're doing is adapting it to physical activity promotion. And what it is it is a framework, but it's not a strict script that we have to follow. So you can take bits and pick and choose what's relevant for different individual sessions. What we've got in front of us is firstly ask. So that's bringing up the topic of physical activity to begin with. And that's not actually one of our 5A's. That's just a nice little add-on at the very start. We then look at our assessment. So looking at both our subjective and objective assessment of physical activity. We then move on to advice. So the clinical guidelines that we're giving our patients, the advice that we're delivering it, but really looking at delivering it in more of a motivational interviewing style technique rather than just that blurting out information to patients. We then look at agree, so collaboratively setting goals with our patients. And then assess, so that's looking at that action planning that Jen was talking about before. So really identifying patient strengths and potentially what's getting in the way and coming up with some strategies around that. And then lastly, arrange. So that's looking at that onward referral, how we can support them in the community, and looking at after discharge, how are we confident that they can then help themselves more into that future. So to begin with, just bringing up that topic of physical activity, something that we do recommend that you try and do in most sessions, if not all sessions, but it doesn't have to be a big conversation each time you're working with patients. But it's just trying simple openers like, would it be okay if we talk about your movement or your physical activity today? How are you keeping active since we last spoke? Or is some exercise is something that we'd like to discuss with all our patients? Is that okay for something that we do today? So it's trying to keep it really conversational, but that idea of asking permission to bring up that topic to begin with then allows that patient to then buy into the topic a little bit more. So our first one of the A's in that clinical framework is assess. So we're really looking at more of that subjective assessment today and understanding that person that is in front of you. Trying to ask a question about what does your typical week look like in terms of movement? And that can really make it more specific to what are they currently doing, but it can also make it a bit more encompassing in terms of including incidental exercise that they might be doing or something that they might not necessarily consider as exercise per se. We then try and gauge their readiness for change. So that can look at 3 different components. So whether they're in the pre-contemplation, contemplation, or preparation phase. So pre-contemplation is that I'm not really interested in exercise. I've got no motivation to change at all, and nothing you say is really going to change my way of thinking at the moment. We then had that contemplation stage where I know I should be doing more, but I don't know how to start or I don't know where to start, and I'm looking for support. Or that preparation as I want to change. I've started putting a little bit of action into making changes, but I haven't actually started that behavior yet. And by identifying that in our conversation can really help then guide where we're going to place our support for patients. Part of this conversation in our subjective as well is also trying to help identify any barriers that are getting in the way. So patients are very good at telling us, you know, I want to be doing this, but I don't have enough time, or I'm in too much pain, or I don't know how to get there, or it costs too much to do it. So it's starting to bring up, you know, those things that are getting in the way. But then also, you know, if they might be able to identify some of their strengths as well. And we're going to explore that a little bit later in one of the other A's. What we have on the right of the screen is also our confidence and important intervals. So they can be a really nice thing to implement early on in our sessions, in our subjective assessment, to try and work out what is it that's getting in the way to start taking a bit of action. So asking them questions around how important is it to you to be more physically active, or how confident are you that you can start making these changes to be more physically active? And that might really help to identify, you know, is it that they don't hold a lot of importance to physical activity, or that they don't have confidence in themselves to be more physically active? And then that can help, again, guide where we provide more support for patients. Another thing to consider when we're using these intervals is that we're aiming to get 7 or higher out of 10. So we can be pretty confident that, yeah, it is really important to them if they're ranking it a 7 or higher, but also using follow-up questions as to why didn't you rate it a lower number. So let's say that we ask them, you know, how important is exercise to you? And they rated a 4 out of 10. You can follow it up with a question as to why didn't you give it a 2 or a 3 out of 10? And that can really start some change talk. So they might start telling you the reasons as to these are why it is actually important to me, even though I didn't rate it those high 7, 8, 9 out of 10. But it can start that change talk as to why is it important to you. Another thing to try and draw out why exercise is important to the patient is the idea of future casting. So looking towards that future and how things might be different if you started to take action now. So some of the things that we could ask is, you know, what would be different in your life if you were more physically active? Or what does staying active mean for your future self? Or, you know, what would you be able to do that you can't do now? Or who else in your life would notice that benefit of you being more physically active? So it's really trying to put that why first as to why is it important before we move on to the what, being the goals, and the how, being the action planning. The next of the A's is advice. So not just the advice that we're giving, but it's how we're delivering that information. So again, thinking about what Jen was talking about in terms of motivational interviewing and resisting that writing reflex and really leaning into providing relevant information. So again, thinking about that elicit approach that Jen was talking about before. So making information really relevant to the patient, providing them the information that they're after, and then checking back in with them as to what was your understanding, what was your takeaway from the information I just provided. And like I said, avoiding that writing reflex. So we do have a wealth of information and experience as clinicians, but it's avoiding dumping all of that on the patient and providing unsolicited advice. It's trying to really pick and choose the most relevant information to deliver to our patients. And then also considering providing handouts to patients. So we've all been in appointments or come to lectures or learnings where you're given an awful lot of information. And often it is useful to have a handout to take away from that session to really solidify the information that you have been provided. In terms of things that are done commonly and things that we should try and do instead. So it's that resisting that urge of saying things like, you need to exercise to prevent falls. And instead trying to reframe it to things like, exercise can help with your balance and help with how fluid your movement feels. So trying to make it more relevant to the patient itself. Or, you should be doing that 150 minutes of exercise each week because we know the WHO guidelines say that. And instead trying to break it down and say, many people find even 10 to 15 minutes a day can make a real difference in how they feel, make it more palatable to that patient. And this one's quite an abrupt one, but, you really need to get moving. And instead we can say things like, would it be okay if I share what others in your situation have found helpful? And in terms of infographics and handouts, the Moving Medicine, which is a UK website, has a bunch of different resources on there. So some are specific to Parkinson's, and then there's a lot of other conditions on there as well. But just another kind of resource that you could use to help solidify the information that you are delivering to your patients. So after, we've provided our advice, hopefully in a meaningful way, we then can move on to agree, which is our goal setting. So when we're talking about goal setting, it's really trying to make it a collaborative approach with our patients, but thinking about not just SMART goals, but smarter goals, which then help support behavior change. So making them enjoyable and then making them repeatable so we continue doing them into the future. When we're thinking about setting our goals with our patients, what can be useful is one, linking it to what is important. And we can do that through creating a bit of a vision statement. So, in 12 months' time, where do I want to be? What do I want to be doing? How do I want to see myself? So thinking about that objective goal that Jen was talking about before. So we can pop that into a sentence like, I want to, whatever it is, so that I can. So really creating that vision of what they want to be doing, how they want to be feeling in that future. And then we can really strip it back and make it smaller. And these are the stepping stones to build ourselves up to that big vision that we want to see ourselves doing. By making smaller goals, it makes it a lot more achievable to kind of, this is how I get to that big thing that I want to achieve. But it can also really help build motivation that each time you tick off one of those small goals, it can really build on that motivation and push you more towards that intrinsically side of that motivation spectrum that Jen was talking about. One thing that you could say to try and help set those smaller goals with your patient, especially if you don't have much time within a session, is that idea of, what is in your power to change between now and the next time I see you that works towards that big vision that we just talked about. And often, they might be able to identify something small that they can manipulate or change within their week. That might not necessarily be a physio-specific goal, but it is something is better than nothing, that working small things, small changes. Another thing that we can consider when we're setting goals is that confidence interval that we spoke about before. So, we've said that, between now and next time I see you, I want to walk to the letterbox 2 times over the course of the week. And then following it up with, how confident are you that you can actually do that? And if they're scoring 7 or higher out of 10, then we know that, yep, they're pretty committed to that goal. We are confident that they can achieve it. If it's lower than that 7 out of 10, it can also be an indication as to, we just need to reframe it a little bit and maybe make that goal slightly smaller and more achievable for them to really promote that success and build on that motivation. Another thing to consider when we are setting goals is actually checking back in on that goal. So often as clinicians, we're really good at having that initial assessment sheet, setting some goals in that, and then maybe not checking that until we're up to discharge for that patient. So really considering how we checking back in on those goals and making patients accountable to the things that we have set out to do. And it's also normalizing setbacks, that we don't always achieve 100% of the goal, and that's okay. That is very normal. It's taking more of that experimental approach to the goal as to, okay, this is how you went. These are the things that didn't go so well. What could we do differently? And how can we reset that goal to continue moving forward? Another thing that you can do is, link it back to, I achieved, 80% of that goal. So rather than looking at goals as, just a pass fail, I achieved it, I didn't achieve it, therefore I'm a failure, is looking at more of that school exam grading system as to, I didn't achieve the goal completely, but I got 80% of my way there. And that's still a really good pass if we're looking at it from that percentage. When we are checking back in on goals, is asking questions like, what got in the way? What stopped you from doing it this week? Or what do you think you could do differently to increase your chances of success? And then checking back in as to, are you happy to try a different approach? Let's take it like an experiment, and we've tried it one way. Let's try it a slightly different way and see how we go. After we set our goals, we then go on to assist. So that's our action planning. So we've got our goal in place, then we want to create a plan around it to try and help succeed in achieving that goal. And what we try and do is explore our strengths first before we look at the barriers. Like I said before, we know that patients are very good at identifying barriers, but they're not so good at identifying their own personal strengths. So that's what we try and really prompt them into demonstrating to us early. When we're talking about strengths, we try and look at a few different subcategories. So one of them can be past experiences or past changes. So, what have you done before where you've set out to achieve a goal, and what strategies did you have in place that helped you to succeed? So it might be, I set up a really good timetable and I'm routine driven. And once that was set up, I succeeded in achieving my goal. It's looking at personal qualities. So what personal traits do you have that help you to succeed in different avenues that you have in life? So it might be, I am really self-determined, or I've got a really good ability to laugh at myself and I approach things with a lot of fun, or I can be really disciplined once I set my mind to something. Looking at those social supports around us. So who do you have that's in your corner? Who can encourage you and in what ways? So it's, do you have a spouse that can participate in exercise with you? Or do you have a family member that can help get you from point A to point B to attend an exercise class? Or, do you have a friend that might call and check in on you and provide you with a little bit of accountability to achieving what you've set out to do? So also considering things like our energy windows. So knowing what time of day you are most likely to participate in exercise. So some people just aren't early risers and don't want to exercise first thing in the morning, where it works perfectly for others. So trying to identify when is the best time of day for you to exercise, and how can we plan our day around that to embed that in. Doing things for enjoyment as well. So what have you done in the past that you've enjoyed in terms of physical activity that we can lace into your current exercise routine? And then thinking about that environment that's around us. So, do you have access to different equipment within the home that we can utilize for your home exercise program? Or do you have a local gym that has an exercise class that you can attend? Or do you have really good walking routes that are close to nature around you? What can we utilize in that surrounding environment that can help set you up for success? And then we can explore the barriers. So what is getting in the way? Is it weather? Is it pain? Is it time? They're all common themes that we see with our patients. But it's not just identifying what is it that's getting in the way, but then going through each one of those barriers and talking about the strategies that we can use to overcome those barriers. So, okay, I'm not really good at exercising when it's hot outside. What can you do to overcome this? Can you think of anything that you've done in the past that's helped you exercise when it's really hot outside? So it might be swapping a walk outside to doing something indoors where you've got access to a fan or air conditioning. So when we're building that action plan, it's thinking about if then planning, so making it really specific so they know exactly what they're going to do. So for example, it's if it is a Tuesday morning after breakfast, then I'll walk to the end of the street and back. If it is too hot, my plan B is to turn on YouTube and do a 10-minute video in front of my fan. Or utilizing things like habit stacking. So linking exercise or routines to something that is already embedded into your life. So something simple like after I make my morning coffee, that's when I'll do my 10 minutes of exercises. And that way I remember to do it because I have a coffee every single day. It's building in accountability into it as well. So how are you going to track it? How are you going to use those self-monitoring techniques? Are you going to tell someone to check in on you? Are you going to write it on a calendar so you get that visual reminder? What is it that's going to help instill a bit of accountability into that plan? And then considering the 4 E's as well. So is it enjoyable to do? Is it easily accessible? Are there not many barriers? Is it essential to you or is it important to you? And is embedded into daily life. So when we're thinking about those 4 E's, if we can tick all of them off, we're more likely to develop an action into a habit. And lastly, we have a range. So that's looking at our follow-up. So our follow-up, our referral system and the support and looking at, towards the end of our treatment plan and post-discharge, how can we really support patients to continue on what they're doing? So we've talked about self-monitoring tools, so things like activity diaries, different apps and pedometers, different wearables. How are you tracking what you're currently doing to help increase that motivation and not just motivation, but that internal motivation to continue what you're doing and keep yourself accountable? What's the follow-up system look like? So potentially towards the end of treatment when appointments are getting further apart, is there ability or capacity to maybe do a really small follow-up as to how are you getting on with those goals? Good, not so good. What can you do differently? And keep it really brief. Or is there someone else in their life, their support network, that might be able to follow up with them to check in on their goals and increase that level of accountability? Thinking about our community referral. So what is out there in the community? Do you have your own directory or can you access one that's already established to look for local services that you might trust and be able to refer to? And considering, what is out there specific to Parkinson's disease as well. So are there neurological exercise programs? Are community trainers experienced in dealing with people with neurological conditions and Parkinson's disease? What support groups are out there as well? And again, looking at that social support. So who else can be part of that plan to help support them into the future? And again, it's looking at from that emotional, strategic, and practical perspectives. In terms of, what is in the community, so in New South Wales, we have Active and Healthy website. So that's for older people. It's quite a detailed website with a lot of different resources on there. Lots of the local councils have community directories as well. So this one was from the Northern Beaches Council. And then we've also got the Promote PA activity directory as well. In terms of, Parkinson's specific stuff, it can be tricky to find a lot that's out there. But, you've got Dares for Parkinson's Australia, which has a lot of classes across all of Australia. Down in Cogra, there's a studio called Live Well Health and Fitness Studio that has a Parkinson's specific class where their trainers have been trained up for it. Up in the mountains, there's a Parkinson's support group, and they also have ping pong for Parkinson's. So it's really trying to look at, what is out there, what can we find, and then share it amongst the wider team as well. In terms of the 5 A's in general and the common pitfalls that we see and what we should be doing instead. So one of the biggest ones is that righting reflex of telling patients everything we know because we want to do the absolute best we can for them, rather than leaning into that illicit approach. Setting goals without the why. So instead of really thinking about what is important to the patient, setting goals focused around, physio outcomes. So what we really should be doing is, finding out what's important to the individual and setting that goal around that. And then before we start making that action plan. Setting goals that are overly ambitious. So really linking back to that confidence interval. Are they scoring it higher than a 7 out of 10? And if they're not, we need to make those goals. You don't have to change them completely, but make them a little bit smaller and more attainable for the patient. Not having any follow-up to our goals either. So without that follow-up, we don't have that accountability. So not just setting that goal with the patient, but really embedding into our treatment plan as to when we're going to check up on those goals. And then again, that information overload. So dumping too many facts to patients that's unsolicited, and really leaning into that elicit, provide, elicit technique. In terms of, as clinicians, what we can do to embed physical activity promotion into everyday practice from an individual point of view, it's adding physical activity questions routinely into our sessions, even if it is really brief in nature. It's considering that 5 A's framework and what we can take from that framework for particular sessions with our patients. It's using that confidence and importance intervals kind of throughout. So it can be used to identify, is exercise important to the individual, or are they just not confident that they can do more exercise, but then also linking it into our goal setting as well. And also role modeling, so your own relationship with physical activity and how that demonstrates to the patient. In terms of, the wider team and how we can embed physical activity promotion, it's including it in team meetings and case reviews. It's sharing resources and referral pathways with your colleagues. It's advocating time for looking for resources and sharing that and having these conversations. And also creating, updating templates. So thinking about your initial assessment template and how you can maybe manipulate that or update it slightly to add maybe some of those 5A principles. So that's an overview of how we can apply practically what we've learned today into more clinical practice. I'll hand it back to you, Jen.
Thanks so much, Jo. Thank you so much all for listening. As you can tell, we're all so passionate about this because, motivational interviewing and health coaching has really transformed our own experiences. We've all had physio backgrounds. So I hope this has been valuable to you today. There's just a few resources that we want to share. If you could go to the next slide, please, Jo, and we'll just overview what's going to be available through the PD Warrior website. Yep, that was an overview of the 3 things that we've got. So feel free to screenshot, download any of the slides that you've seen. I'm sure we can make these slides available to the team as well. Here's a cheat sheet for you, and we've done a 1-page PDF on this as well. So these are some questions that you might want to try in your next clinical interaction. The next slide, please, Jo. There's some further training as well. So if you really want to dive a little bit more into coaching, there's the Wellness Coaching Australia. They're the reputable ones in Australia. I'm not sure about overseas. There's also the Society of Lifestyle Medicine and Dr. Stephen Rolnick, who's that co-founder of Motivational Interviewing. He's got a really fantastic e-workshop online as well. Highly recommend it for your PD points as well. And some really key takeaways. So from those sections, so thinking about section 1, physical activity really is evidence-based medicine, and the barriers are real and we can't dismiss them, but we can certainly help your patients to address them. Thinking about section 2, so behavior change needs that diagnosis. So the capability, opportunity, motivation, and that approach, finding that why before the what and the how. And then in section 3, Jo did a really wonderful job of giving you that 5 A's framework, and that's a flexible, patient-centered framework. And even, a really brief structured conversation can make a big difference. So I'd love you to think about, what's one thing you've gotten out of today, perhaps a question or an insight that you're going to try in your next clinical interaction. So thanks so much for watching on behalf of Leanne and Jo. I'd love you to get in touch if you've got any questions. You can find us on our University of Sydney emails there. Leanne is on LinkedIn and Jo and I are both on Insta, and we're sharing content around behaviour change and motivation. So feel free to jump on, check out some of the stuff as well. We would love to hear from you. And thank you again so much for watching. I hope you found this valuable. Bye for now.